Good afternoon, everyone. Usually Friday, something to be celebrated, but it's a bit sad. It's the last day of our conference, but don't worry, there's still plenty of good things to come. So we've got two amazing presentations and then Corner House tonight, which is something to get excited about. For Corner House, just a reminder, 7:30 start. We'll be putting drinks on for a couple of hours there. I think there's the option to get some small bits of food, but probably best to have some food before you rock up. So 7:30, Corner House tonight. Same as yesterday, we've got some great prizes to give away. So we've got a Dan Murphy's voucher, we've got a Rebel Sports voucher and some EMS t-shirts. So thank you for everyone for sending those photos in. I think the photo competition's officially closed. So unless it's something remarkably excellent, maybe save that one for next year. And we'll also be drawing the lucky winner of the iPad 10 thanks to Locum Life. So that's definitely something to get excited about. Edge of your seat kind of stuff there. Yeah, Dylan liked that one. It's now with great pleasure actually welcome Kim, Tahlia and Amanda for our first presentation. And Kim has actually, I think this is your fourth time presenting for us and third time in Bali. So thank you very much, Kim, for that. And also it's great to have Tahlia back, who presented for us in Queenstown, and Amanda, who's brand new to the presenting circuit, or the international presenting circuit, as we like to call it.
Amanda is popping a cherry, if you can call it that.
So let's start things off with a big round of applause for the guys.
Hey guys, I might just ask, because we've got lots in this row, and we are going to be interactive, if we can maybe move some people up so it's even. Do you think we could do that? Like, I'm not going to make you role play or anything nasty, but I just think it's easier if I have it a little bit contained, because I will be roving a little bit. I like to walk while I talk, and I like to be interactive. So can we move? Is that okay? Thank you. I'm also not so good at buttons. I like to press buttons. I'm personality A type. I just press. So if I press too often, then Quinton or Dylan or Tahlia, she's actually my daughter, will fix it. So, you've gone too quick for me. So firstly, I'd like to thank Jacqueline and Quinton and EMS Conferences for having us back again. We are passionate about mental health. That's what we do. It's what I've done for 34 years. I am passionate about making a change in the mental health field. We do like to be interactive, and I do have some interactive sessions within this. So again, no role plays. I'm not going to ask you to do something out of your norm, but I do like some participation back. So, but in saying that, what we're going to be talking about may cause, because we're talking about a bit of trauma, so it's just acknowledgement from the beginning. If we cause any trauma in anybody in the audience, please feel free to walk out and come and see us later. That would not be our intention, and that's not what the talk should be about. But with any talk, we have to acknowledge that. So as Quinton said, my name's Kim. I've been in mental health for 34 years, which makes me feel really old. I've worked over all facets of mental health, predominantly my expertise is in acute mental health. I've done private practice in addiction, in neurodiversity, and as well as acute mental health, as well as working publicly. So my aim is that I am the co-responder with Queensland Health, and this is what this talk is about. Tahlia, I don't know what you call it, you nominate, Tahlia is my daughter, which is, I'm proud to say that she is a fabulous CN clinician with the acute care team. When she wanted to go into mental health, I said, really? Maybe do critical care? But no, she wants to do mental health. So Tahlia has expertise in high dependency units, in PICU units with mental health, as well as working in the child and youth sector with mental health, and then has come back into the acute care team with my team, which I work, and specialises within the ED. She has some family therapy training, eating disorder training, and specialises in trauma-informed care. Amanda is our mental health social worker. Amanda has worked in mental health from 2014 and specialised. She's also a family therapist, and at the moment is working within education at schools, but also works from a trauma-informed lens, which is a bulk of what our talk is about. Do you want to click? So this is a quote I always use because it never gets old for me. So when we work within emergency settings, we always want to work within a seamless practice. Is that right? Yeah. So we don't want to work in silos because that's no good for any patient, whether it's mental health or whether it's a physical health. So I love this quote by Henry Ford. So it's coming together is the beginning and keeping together is progress and working together is success. And I think that always drives us. So a bit of the introduction agenda. We will be giving a brief snapshot of Gold Coast Mental Health Service, why the need for change. I will be doing an interactive, a little bit of a session, but again, no role plays. We will be talking about a little bit on trauma-informed care, bias, stigma, discrimination, seclusion, restraint, staff attitude. There is a commissioned report. Does anybody know the commissioned report? Has anybody read the commissioned report in 2020? Nowhere else to go. Anybody read it? No. So it was commissioned because of the increase of mental health presentations to ED departments across Australia. It's a really interesting read, and I have got a link there for you guys later if you want to link into it. Yep. And the bulk of the talk is going to be on the co-responder model, which we have adapted, which is interesting to note. In 2020, this commission report highlighted what we're doing on the Gold Coast. So they highlighted that what we do is different, it's innovative, and it's making a change. So that's the bulk of the talk. I could do a presentation for 2 days on all of this, so we have really tried to condense it. So I want you guys to ask questions, I want you to be interactive, and if we need to do further talks, we will do. But I also know that there is in the audience my colleague, Sarah, who's a CNC, currently to be a nurse practitioner, that I use a lot when I bring people in. There's also Rachel from Robina. Where are you, Rachel? Yeah, there she is. So I also know there's apparently meant to be paramedics here from Queensland. Can you put your hand up if you're a paramedic from Queensland? Yep. So what part of Queensland? Toowoomba. Same? So just 2 from Toowoomba? 3 from Toowoomba. 4. I did try, and this talk was originally meant to be a dual talk with our LaRue officers, but you guys probably from Queensland Ambulance know the protocol is so hard. Like, I actually had talks and we cannot show them because Queensland Ambulance won't acknowledge those because it takes months to get through the process. But I can talk about their perspective as well. We will talk about the results, improve consumer experience in ED, the ED avoidance strategies and co-design models through partnerships. I just want to also put because I'd like to know my audience. So who is a paramedic in the audience? Great. Who's ED? Okay, wow. Who is allied health? Any allied health? Oh, Amanda. Who is mental health? Who likes to work with mental health? And this is not a trick question. Great, there are some hands up, that's fantastic, because lots of people often say they don't like to work with our mental health consumers. And I acknowledge it, they're hard. We all acknowledge it. So thank you for putting your hands up because you're great. We have a huge passion to drive what we do forward and to try and push our wheelbarrow up the hill to make change for mental health. This is us. I'm not going to talk in depth. You can see it on the screen. So Gold Coast Health Service, we're probably more than 700,000 now. After COVID, we had a huge influx that came across our borders. Once the borders lifted, I think there was, Sarah might correct me, I think it was 153,000 that migrated to Queensland, which was huge. There was no increase in our infrastructure for that. There was no increase in our housing. The prices market went through the roof. So we have a huge now accumulation of homelessness, people that can't afford rent. And we know that mental health after any pandemic or any disaster becomes the pandemic. And that's what we're going to see for the next couple of years. Mental health will be the pandemic post-COVID. That's a little view of our hospital. So we originally have 2 ED teams. So Sarah, as I said, is a CNC from Gold Coast. Rachel is from Robina. In mental health, we have community mental health teams, child and youth. We have our Evolve Therapeutic Services, which is for our more high-depth youth. Use your microphone. That's the mother in me. Use your microphone.
It's children in care under the care of child safety, so they have to be under an order to be case managed by Evolve.
We have our perinatal infant mental health, our early psychosis team, our continuing care teams, our older persons mental health, our homeless health outreach, our AOD service, our mobile intensive rehab teams, our eating disorder services. Okay, so our specialist service is service integration coordination. We have consumer care and family participation teams. We have our mental health intervention coordinator, offender health services, and we're actually building a brand new forensic mental health facility behind, I think, our Gold Coast ED. Yep. So that's going to create a lot of jobs where we don't have enough qualified staff. So this becomes also an issue for us. We have an increase of need and not enough qualified staff. We have our multicultural programs, our, as I said, community forensic team, our suicide risk and management team, our ATSI, mental health recovery, GP liaison. Now that's recently been changed to the point that we have added now any GP can ring for any mental health support and speak to a consultant psychiatrist to try and avoid those GPs sending unnecessary presentations. But we need to get the word out to those GPs, and that will take time. We have our CL psychiatry, which every hospital will have, and we have our interdisciplinary persistent pain service. Okay, so in our acute care services, the acute care community team, we have our acute intake team. Recently, we really changed in lots of aspects that we used to rotate through all these teams. Now it's changed. So the acute community teams stay as put. Our ED teams and our intake, which is our phone reception, they rotate through. We have our recovery team, so post-discharge, the recovery team becomes involved. We have the mental health co-responder, QAS and QPS, which I do both. We have 9 mental health inpatient units, 2 campuses. We have 154 beds only. So those beds haven't been increased as we've increased with the population, which is interesting to note, and we're always bed blocked. We've been bed blocked since 2014. We never have free beds. And we also have established a crisis stabilisation unit, which has 12 chairs. So why the need for change? I'll get to that a lot more, but it was about bringing together key stakeholders to build robust relationships. We know lots of people don't need to come to ED. So how do we change that? Because normally ambulance have no other option, police have no other option. So how do we change that? We want to reduce the incidence of restrictive practices because we know that impacts our mental health population. And when we get to that in a minute, we'll tell you the percentage of people with mental health that have trauma background, and it is massive. So bringing to ED often re-traumatises patients. We want to reduce the average length of stay for mental health patients when transported through ED because it's often lengthy, and we know that the bed blockage plays a part, but there's also other aspects that will come through in research that I'll show you in a minute that plays a part to that. We want to streamline the consumer's ED journey for patients transported to hospital, and we want to increase community-based mental health service provision to reduce the reliance on ED because we know there's lots of reliance on ED. I would say it's Australia-wide. Am I wrong? Is there lots of resilience on EDs? Yep. Okay. We want to improve consumer outcomes and satisfaction. We want to improve integration and collaboration between the mental health service, QAS and QPS. And, of course, Gold Coast EDs, because they're pivotal to us. So we facilitate reduced QAS and QPS responders' time per job because it is large. And I'll get to that when we look at what we do as the co-responder. So before us, the time spent and the ramping time was massive. So we want to reduce that. And we want to streamline medical clearance and referral access and improve the overall health and emergency service collaboration in delivering care. So this is the interactive bit. and I know everybody hates interaction. Mental health, it's essential. We don't get through mental health without having to do, and again, not making you do a role play, but when I did my training 34 years ago, oh my God, we had two-way mirrors. I did training in child and adolescent mental health. You would have your facilitator on the other side, and you would be grilled on what you did. So I don't want to facilitate that here, but I'm just wondering if we can just have a thought about, and think to yourself, because I'm going to ask you to call it out, if you can think about some of the emotions that when people come in with mental health, they're attached to those people. So I'll give you a couple of minutes, write it down on your piece of paper or just think about it, because I'm going to ask these girls to write it up. There's so many emotions. It's where you need to sing a song in the background, like, woo-woo.
If anyone wants to yell anything out, Amanda's walking around with a microphone. Just flag her down.
It's how they can write it up on the whiteboard. Up here. Anger, absolutely. Absolutely. Yep. So you got anger and anxiety. Oh, you give me the clicker. Gee, that's dangerous.
By the way, I can't spell, so don't judge me on this.
And that was not my responsibility as a mother. My father was a school principal and I was an atrocious speller. And everybody would say, how can you not spell? Your father's a principal of a school.
Kim, we've got loneliness as well here.
Loneliness, so anger, anxiety, loneliness, yep. Frustration, absolutely.
Sometimes dread.
Dread, absolutely. Fear, thank you, Sarah. Sadness, yep.
Really happy.
Helplessness, absolutely.
Really happy, they're like mania.
What was that one?
Mania, sometimes they're really happy.
Yep, so elevated mood, yep.
Abandonment.
Abandonment, absolutely. And that's where we'll get into the trauma-informed care in a minute, absolutely around that. Shame, yep. Scared? Absolutely. Very distrustful.
Aggression.
Aggression, yep. Agitation, yep.
Guilt. We've got
Guilt.
here. Yep.
Anything else? You've summed a lot of it up, which is great. But I like to, when I do this, I like to make people reflect, because this will come further in the talk, why I've asked you to reflect on that, because it's quite important. Okay, I've been given the clicker, look out. Oh, here. So I just want you to pair up with somebody, and I just want you to explore the emotions of anger and sadness, for one. I want you to reflect on, because we've all had it. Have we not had all anger and sadness in our life? Yep. I want you just to discuss with somebody what's helped you in those times and what wasn't helpful. Just take some time to write it down, and then we're going to ask you to call that out as well. Because I think often when we work in emergency services, we don't often take a lot of time to reflect. And I often say to my staff, I want you to think of if this was your family member, if this was your daughter, your mother, how would you want them to be treated? If this was yourself. Because let's face it, mental health affects everybody. At some point, we're all going to be affected by mental health. Doesn't mean we all have to come into ED. It doesn't mean we all need a mental health assessment. But mental health affects everybody, whether it's a bit of anxiety, and we've all had that, a bit of lowered mood. I know my father died last year when I came. It was quite raw to me. I had to come to the presentation. I'd nursed my dad. He'd recently died. There was lots of sadness and grief at that time, and I was still trying to present a presentation. So if you can just discuss, and then I want you to call out what has helped. So maybe flip it, Charles. I want to know it's stuck. Turn it.
Oh, I'm just going to put it down here, guys.
Okay. We don't want to flip the whiteboard and then cause a disaster. So I want to look at what has helped you and what was unhelpful. I know recently, and I can, share my, Amanda share with me. So we came over recently with my brother, his family. So after my father passed, my mother had to move in with me. It was never planned. My partner had a massive accident and fractured C1, 2, 3, 4, 5 and 6 of his neck. His spinal cord was completely squashed but not severed. How he didn't die or became a quad is a miracle to all of us. He had a frontal bleed and a left occipital bleed. He also fractured 9 ribs and a fractured ankle. So he came with me last year. He was a week out of a hard collar after 6 months. We avoided the halo. And he's got significant memory loss and his filter is absolutely gone. Like, I'm looking at a man going, oh my God, you can't say that. But he does. And I think we often reflect how we would want to be treated in that situation. And so my brother, Amanda and I had a few drinks with my brother, and I was trying to say, you guys need to support me. I'm supporting mum financially, I'm supporting my partner financially, cost of living's going up. Like, where does it end for me? Can you help? And he said, no. He said, I love mum, but no, that's up to you. So after a few more drinks, when he wouldn't help, I became a bit emotionally labile after a few drinks and gave it to him. He put a hand in my face and said, tone down your voice. That was not helpful. So you can imagine your response to that. Look, we made up next day. But anyway, but that's an overshare. But that's, I want you to reflect on what's helped and what doesn't. Because what I often see when people come into ED is the difference to what helps and what doesn't help. So maybe just call out things that have helped. Firstly, for anger, taking the time to listen, absolutely. So feeling validated, yep. Genuine, absolutely. There's nothing worse than somebody not being genuine to your face, and you pick it up. So that's a positive or negative? Offering positives. So positives offering warmth. So that's on the other side. Yep, what else has hindered or helped? Rachel? Not being dismissive?
Empathy.
Absolutely. Because to the person, it's what's happening for them right there and there. It doesn't matter that we don't think that that's needed, but to that person, that's real for them. Amanda?
We've got empathy up here.
Empathy is a positive?
Love that one.
Absolutely. So empathy is a positive. Patience? Yep. And do we have the time for patience normally in ED? No. We're very rushed, aren't we? Yep. Amanda?
Just knowing that you have a mechanism that you can vent to. Because if you don't have a place to take your anger to, that is part of it. And sometimes the only thing that's left is either the team that you're with, the partner that you're with, or you bring it home. So having that escape, that relief valve that
Yep.
you know is safe, that you can use at work.
Yep.
So like
And-
a safe space.
And often when people come to ED, they're past that. Do you know what I mean? Like, it's built up this huge issue. Yeah? Anybody else? Asking them? So being genuine and asking them what's wrong. Yep. 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 Absolutely. Because can you imagine, and we used to do an exercise previously where you come into ED, you're heightened, and you're asked in front of everybody what's going on. I know if somebody was asking me, is that something you want to just say up front in front of lots of people that are going to hear? We're asking people to explore really in-depth emotions. Yep. Time? Absolutely. So in times are different. It's a difficult thing, isn't it? Because in mental health, compared to physical health, so often when we do an assessment in mental health, it takes time. And depending on the physical vulnerabilities and emotional vulnerabilities, it takes some time to bring all of that out. And so we often get pushed, like, when are you going to see the next person? Okay, but we need to explore what's happening for this person. And we don't want to spend hours and hours discussing their emotional health, and we'll often say this is a psychiatric emergency, so what can we do? But you do need to validate the person, absolutely, and find out what's happening. None of us, I don't think anybody here, would you go to somebody that you've not met, cop all this? And I'm amazed how many people tell me the in-depth stuff that they tell me, because I wouldn't, but they do. What about anything else there? Because that's good. It's absolutely good. And I want you to keep all of that in mind, because I'll come back to that in the next reflective session that we have in a minute, yeah? But I think we can all look at what's happening. And I always keep saying, thank you, I call it blue sky thinking. I always say to my staff, if this, as I said before, if this was your mother, your daughter, your son, how would you want them treated? You know, when my father was dying, and look, I had the links, and they were great. But I did have a time when we went from, and he was palliative, and so when I took him in, we called the ambulance, and he was palliative with cancer, and then he had constant diarrhoea. So my mother called me over and says, the night before she'd messaged me, I was at work, he's vomiting, he's not making much sense, he's dragging a leg. They had the palliative care coming the next day. I went over, I said to the palliative care nurse, you need to call an ambulance. I said, I can call the ambulance, I work with them, but I really think that's a bit of conflict of interest. I can push it, but my dad needs to be assessed. By the time we got him in, he was dying of acute kidney failure. So I think his kidney score was 4. So basically we got given 6 to 72 hours. So we have to think of how that impacts on people. Yeah? You got the clicker? So you've all nominated lots of what we see. So it's often linked with distress, agitation, those heightened emotions, which are really difficult to deal with, and I get it. You know, you guys are on the front end, you know, and they're difficult. And this can result often in suboptimal treatment, which is what we sometimes have to resort to, which is restraint. So again, we'll get into it in a minute around trauma. So you're restraining a trauma patient. So just have a think, if somebody's been, you know, abusively raped for many, many years, how does that feel to be held down? Because they will be re-traumatised. The use of sedation, often it prolongs your stay in ED, because then you have to care for them. Then you need one-on-one care. And seclusion, and we'll get to that in a minute, because there's a further talk on seclusion. So this is over to Tahlia now, because this is Tahlia's love and passion, trauma.
So we look at trauma, it's any single, ongoing or cumulative experience which is a response to a perceived threat, overwhelms one's capacity to cope and evokes a psychological response or a set of responses based on fear and avoidance. So there's an estimated 90% of individuals who access mental health services who have experienced trauma.
That's massive, I must say.
And then it's 75% of the general population. So it's huge when you look at the amount of consumers presenting to any kind of service.
And I must say, even for your general population, so 75% of people coming in for any general care, research shows have had an experience of trauma. So even when it's not mental health, and even when you're just exhibiting general care, we need to be aware of trauma and the impact that we can re-traumatise.
You've got bias. So bias is a preference in favour or against a person, group or people or thing. This is a human reaction, often unconscious. It's part of being a human being, and it can be potentially quite harmful.
There was a speaker in Queensland, a paramedic, that spoke about bias, and it was a really interesting talk. And she brought up lots of cases from coroners, where when we looked at bias, when people weren't treated the same as another person, that bias played a part. We all have it. That's, as Tahlia said, it's part of being human. But what I often suggest to my staff and in this training, we need to be aware of our bias. And if it's coming into play, just reflect on that.
So trauma-informed practice. It's an approach that's holistic, empowering, strength-focused, collaborative and reflective. So if we look at the core principles, we've got safety, trustworthiness, choice, collaboration and empowerment and respect. Those are all kind of things that we want when we want to access support. It's important that healthcare professionals know and understand the relationship between childhood trauma and the adult psychopathology. So healthcare professionals work within a framework that promotes mindful practice, empowers consumers, families and stakeholders to support and safeguard independence.
I must say we could do a talk on trauma alone, and I think that might come in the future, but trauma is huge.
It's also a major public health issue, and it's frequently unrecognised and under-addressed. And many individuals have been re-traumatised within the healthcare system as they lack the knowledge, training around sensitivities, vulnerabilities, and particular triggers for individuals who have been impacted by trauma. And this also causes long-lasting adverse effects. So you're limiting one's ability to function, achieve their mental, physical, emotional, social, spiritual well-being, all of those things. So if we then look at re-traumatisation, it's associated with feelings of vulnerability, neglect, shame, fear, anger, agitation. Individuals have experienced ongoing bitterness and anger up to 1 year later, which in turn impacts on them accessing support and their future engagement with services. So best practice often promotes to try and engage individuals into treatment voluntarily rather than involuntarily.
Now playing individuals with trauma.
And we can look at seclusion and restraint. So these should ultimately be the last resort and to manage behaviour to avoid imminent harm to that individual or to others. However, concerns have been raised around the validity, can't say it, and damaging effects of these interventions with particular focus on re-traumatisation to those individuals. So consumers often perceive seclusion negatively, and it's associated with feelings of anger, punishment, and feeling overpowered.
And I'd just like to note on seclusion, there's lots of great research actually on a patient's perspective of seclusion. So often when patients are secluded, they're often psychotic. They're often coming in, they're expressing auditory hallucinations that they're about to be harmed, a family member's about to be harmed. And so when we lock them up, they say, you lock me up with my fears and I'm alone. And I'm stuck in this room and I can't get out and I'm scared shitless. I'm scared that my family members are going to die. I'm scared the nurse is going to kill me. And if we reflect on how we would feel in that situation, it would be an awful situation to be in. And I know we have to use it sometimes, I acknowledge that. But often when we get into it, we'll look at how we can try and prevent that. Because to re-traumatise somebody, again, as I keep saying, look at what this would feel for you or your family member.
Can I just add to that too, in thinking from a cultural perspective and working in Australia with our Indigenous peoples who are a minority group and have a high mortality group, and that often, they come from a history of being in justice systems, secluded, taken from family homes, those sorts of things as well. So when we think about seclusion, what that is like for them in that space, it's a re-traumatisation of the historical experiences that they've had as a culture. So I think it's just really important too to think of that not just as in a seclusion of our consumers, but the cultural perspective on that as well.
Yep, thanks, Amanda. We want to look at, along with bias, which we spoke about before, there's lots of stigma and discrimination. Everybody would know that in ED. You can all nod that we do have stigma and discrimination. Yes? Does anybody disagree that there's stigma and discrimination with mental health? Okay, great. So stigma is when someone sees you in a negative way because of your mental illness. And we all see it. We all have our frequent presenters, yeah? They're all like, oh, such and such is back. They're just like wasting our time. So they're stigmatised before they even get to speak to us about what their issue is. Discrimination is when someone treats you in that negative way because of your mental illness. And both can make that mental health problem worse and impact on the person receiving or reaching for help in an adaptive manner. So often there's lots of research when we speak to patients that they often don't reach for help early, and then it gets to that crisis point. Emergency services are then had to be called because they've lost their ability to put in place anything to self-soothe, and then we re-traumatise again. This leads us on to staff attitudes. And look, we could talk about this forever, but this is another exercise, so I've turned the board around preemptively for Tahlia. So I just want you to think about what behaviours do you see that mental health patients bring to ED? And just shout them out for Tahlia. You moving the board? Self-neglect? Yep. She's coming.
Let's turn it around.
Anything else? It's like, what was that show where, they wheel the board around? Oh. Was it Perfect Match or something? Anyway, I digress easily. Personality A. So
I'll go with aggression.
Aggression? Yep. Absolutely. Disruptive? Bizarre? Yep. Violent? Manipulative? Self-harm? Yep.
Agitated.
Agitated? Absolutely. Thought disordered? Yep. Thanks, Sarah. Withdrawn? Yep.
Intoxicated.
Intoxicated?
Paranoid.
Yep. Drug affected? Did I hear somebody say? Yep.
Yep.
Delusional? There's lots more, but that really sums up the bulk. Yep. Do you want to just do my little clicker? So if we look at societal stigma, so particularly concerns that they pose are safety risks to self and others. And this was from Clark et al. I can't remember the year, I think it's quite recent, but there's really great research out there if you look at ED staff attitudes towards mental health. Has anybody researched that, just for interest's sake? It's a great research to look at. What it really nominates is that there needs to be much more research around how emergency services manage mental health patients, and that will come in the commissioned report in a minute. So some staff comments were as follows: you're wasting my time. Suicidal ideation, attention seeking and behavioural. So often I hear it in my own staff, let's give them a therapeutic weight so they learn. So I say to myself, wow, if I was really distressed and I was given a therapeutic weight, do you think when we spoke earlier about what helps and what not helps, would that help me? But we all do it, and I hear it in my own staff. Say it. Anything else that anybody else has heard? Anybody got any other reflections on what they've heard about attitudes, what mental health patients or even any patient says? Yep. Yep. Absolutely. Absolutely. They hear everything. So when even we think they're not hearing, they hear. And I used to say to my staff, even, so I'm a CNC, and when I used to work in drug and alcohol, these patients aren't coming in going, I'm going to make Kim's day a real shit day. They don't know me. They're not coming in to make my day shit. They're not coping. Something's distressed them, and we need to look at what that is. They're not coming in to make your day shit. That's not their incentive. So when we look at the research, it also shows positive interactions. So lots of research is about the positive interactions that mental health patients get, and there's lots. So it's not all negative, yeah? And as I keep saying, I see it on both sides from mental health staff as well, and we'll get to that in a minute, why that is. So ED is a 24-hour service. It's okay, I can know this bit. So you're always going to get mental health patients coming. No matter what we put in place, you will always get the ED as the front door. How many of us have crises between 9 to 5? I would say it's very limited. Yep. So often services aren't out there. Yep. So where else do they go? And we know if you look at, and I haven't got this in my talk, and this is a research subject, but look what happened over COVID. Most GPs aren't bulk billing anymore. So how do people afford to get to a GP? I have to wait a week to get into my GP. So if I'm in crisis, how do I get that met? And I have to pay. To get to a private psychologist or psychiatrist, it's great for long-term work, but you can't get in straight away. You will have a long, long wait. Yeah? And even most other community services, you're not going to get there in a crisis. There's very limited services that will offer a crisis response. So ED is always going to be a front door. But I suppose when I get to the Commission report in a minute, it's about how we can put other services in place so it's not such a burden on the ED department. This was a bit of research that I found really interesting. So it says, and I'd like your opinions on this, so it says nurses under the age of 35 often show less empathy towards mental health patients. And nurses over the age of 35 often show more empathy. Now, I've seen it go the exact opposite. Absolutely, I've seen it go the exact opposite. So I'm interested in researching that research a bit more. But I think, if I look at what we see coming in with child and adolescent, we're seeing lots more influence from social media. So our young nurses coming out are much more exposed to what happens from social media. Yeah? We weren't. God, when I was young, in order to bully me, you had to ring the home phone and, get my mum and ask for me and then, troll me. Like, now it's just so prevalent. So our young nurses coming through are exposed to that. So it's interesting whether that has an impact. But I'm not saying that because I have seen very young nurses work beautifully. So I would say it goes on both sides, but I'm just saying it's interesting research to look at why. Do you have any thoughts on why that would be? Absolutely. So that was one of the answers, that life experience, that often the older nurses lived life experience, or the older nurse has a child that's gone through a mental health issue. Anybody from Victoria? Okay. I came from Victoria. So old Jeff Kennett, that used to be the Premier. Anybody remember old Jeff Kennett that set up Beyond Blue? Jeff Kennett in my day was didn't believe in mental health, gave no value to it. His son then developed a significant depressive illness. From that, Beyond Blue was set up. So often we see when people experience it from a family perspective, they have more value in putting forward what needs to be done. It's just a bit of reflection to look at. We probably all have mothers. Well, we all do have mothers because we're born. But, fathers, children, brothers. Mental health illness affects everybody. 1 in 4 will have some form of depression in their lifespan. That's huge. That's only one component of mental health. Yeah? If you look at anxiety, and I think anxiety is more prevalent, and again, there's lots of research around why that would be with our youth, but it is huge at the moment. So again, that plays in, impact. But I do think, life experience is a reason why. Anybody else got any other thoughts on that? Absolutely. Do you think training that's changed? Because now, like when I trained back 38 years ago, I trained purely as a psychiatric nurse. I did 6 months of general and the rest was psychiatry. But what I'm seeing with our students coming through is they have very limited exposure to mental health. Unless they've got an interest in mental health, they have very limited exposure to doing a mental health placement. Even with Tahlia, when she was training, she chose placements where she could choose a mental health perspective around it. And I even tried to encourage her to do critical care first, but no, she wanted to do mental health. So I think I see the students and they have...
You do one course at university around mental health and that's about it. It's up to you to do that further education and further training to become more informed around that on your own accord, choosing where you want to go.
And then I think it depends on who is your preceptor, or, we have a list of questions for our students when they come to do a...
even from an allied health perspective, social work, my discipline, so working in the emergency department, the social workers aren't trained in mental health. DV, trauma from accident, those sorts of things, but they're not trained in mental health.
Yeah, and that's a good point, because often we'll see somebody comes in, they make an expression of suicidal ideation. Yep, so they quickly flick to mental health, they're suicidal. Maybe they're suicidal because they've been exposed to their partner beating them up yet again, or some form of violence. And when you speak to them, there's no intent. That is just an expression. So often those people get quickly flicked to mental health, which if we actually explore what the issue causing that suicidal ideation might be, it may be redirected to the right area in the first instance, rather than creating a mental health file for a patient. Yeah. Absolutely. So when I did my training, and that was a long time ago, and it was purely all mental health. So we would do, and I had a hospital placement to be a mental health nurse, or uni. So I was the first ever to go through uni in Bendigo in Victoria to be a mental health nurse. But we did purely mental health. So we did lots of components from grief. You know, back then we did alcohol and drugs. You don't see that now. But yeah, I think you're right, and especially the new nurses. Absolutely. Yep. Yep. Some of those things, and we'll get into that in a minute, and there's another whole talk on that, is how you group that in to how we intervene. So if we look at people with lived experience, and there's a lot at the moment, isn't there, with people with lived experience having a say. I know Melbourne has a lot of input. Again, hands up from Melbourne. Yeah. So there's lots of people with lived experience having input into mental health. We have it at Gold Coast, but they actually give us good insight. So they talk about long harms from those long waits that they get, you know, being put back out into the ED to wait, because it's actually interesting. I think there's a dot point coming up. When you compare the same acuity from mental health to physical, and that comes in the commission report, I think, the mental health stays a lot longer. So why? So you have a cardiac event, a deliberate suicide attempt, and you would reflect, really. And I reflect. I work with the ambulance, I work with ED, but those people with a cardiac event get much better treatment. Does anybody disagree with that? So that plays a part in that person's journey ongoing from there. High stimulus environments. We know ED is not for mental health. We absolutely know it. A person's distressed and their lights are on, there's lots of noise. It's not a self-soothing environment. Yeah, and that actually aggravates the person. So Tahlia's moved me on. So mental health patients, that's different from daughter meeting the mother on, I'll have to do payback. Mental health patients wait longer, as I said, so 18% less likely to be seen with the appropriate triage. 18% if you compare mental health to a physical complaint. That's fairly big. And this is research, it's not just me citing it, this is research. More likely to be a did not wait or leave against medical advice, placing that person at risk. So even before they're referred to mental health, they've left. So they've come in, they're high risk, and there's a, even research says that ED staff think they're high risk, but they leave. You know, how do we follow that person up? Especially if they're homeless, they have no phone, how do we follow that person? And they're 16 times more likely to be brought in by emergency services. That's massive. 16 times more likely. So I'm going to move on to the commission report to the Australasian College of Emergency Medicine. And again, I'll ask, anybody read it? It's quite insightful. Look at my little, lucky there's not coffee stains. Yeah? Nobody's seen this, read it? It's interesting because we do this commission report and it was for ED, but most people in ED have never read it. Yeah, it's never been cited to read. And it's a very interesting read. So I do have a link later on to look at. So the data confirms that mental health patients in ED have excessive and unreasonably long waits whilst in the department. Constant challenge for ED staff to find a safe place to put those mental health patients. Where do you put them? They're distressed, they're agitated. You're busy with your resus area. Where do you put these people? But they need a safe area too. Those dangerous delays and negative experiences are an indicator of widespread system failure. And this is not me, this is a commissioned report for ED. It's not even mental health. So it's ED commissioned report. So it's not even a mental health report. This is your own, if you work in ED, report. It's quite damaging and it's stressful for staff. We know the stress on you guys. We know the vicarious trauma. We know the impact that mental health patients can have on you guys. Absolutely. And I think that's why when we look at why the report was commissioned, it was because we knew there was an increased demand of mental health patients coming to ED. And that's why there's a big push at the moment. I have been speaking at national level at, I think it's access and quality in mental health and EDs. So I spoke in Melbourne in June. I've been asked to speak again in April next year. So they are trying to look at how we facilitated. Interestingly, I spoke in June, most people were directors of ED. Very limited hands-on staff. Yeah. So research also shows that ED staff under the age of 35, which we said, oh, have you gone backwards to me? Okay, we've done that one too. So if we look at the costing, again, this was the 2017 overall costing. There's probably a new one now, I just couldn't find it. But the average cost for all emergency care was $696. So then if you compare that to mental health with diagnostic modifiers, $889. Then compare that to an involuntary mental health patient, $1,074. Then compare that to average cost of distress, confusion, agitation with those diagnostic modifiers. Again, look at that price difference from $696 to $1,225. The cost is massive. And that's why I think there's been lots of push around ED avoidance, but that's a massive difference. So the new models identified across Australia, and I do take pride because we were nominated, but this is in 2020. So PANDA, anybody from Sydney? Yeah, have you heard of PANDA? Yep. So they were acknowledged in 2020 as being a great model of care. Yep. So it's about taking people away from the emergency department, having a separate area, basically. We have in Perth, anybody from Perth? Yep. So have you heard of the MHOA? I think it was Jimba or something or other. That's it, thank you. Yeah, so they have it similar to St Vincent's, a different area outside of ED to see the patients. Yeah, and that led to those from Victoria, the reason why they've started to set up their ED hubs and they're starting to roll out. Yeah. So I know when I went to the conference in June, there was a couple starting to roll out. Does anybody work in an area that has an ED hub? No? Okay. So they're starting to roll out in Victoria because the push is we need to have a different area for mental health patients to be seen. Royal Perth, anybody again work with the homeless team at Royal Perth? There was an interesting consultant, she's an ED consultant, and I listened to her speak in June when I spoke. And so they take their care from ED to the homeless. So they take their care out there. They look at where the need is and they go out. They link with GPs and they do the care out there, which is fantastic. And then we have the Royal Prince Alfred, which is, anybody heard of Tim Wand? Tim Wand's a mental health nurse practitioner. He's written many, many research articles. He's like the guru if you're interested in mental health. So he ran a NP-led mental health liaison service within the ED. So a quick triage, what's needed. Yeah, if people are needed to be seen, they're seen. If they're not, they get referred. And then, of course, down the bottom is us. So Queensland Mental Health, the QAS and QPS co-responder model. So in 2020, they nominated that there was a great model of care that were doing a difference. So how do we fix the problems? So the Commission report says there's so many problems. So how do we fix them? And I've tried to highlight, because so many options here, but it was about improving mental health care across the whole health sector. Okay, and that will reduce the inappropriate, unsuitable and harmful attendances at ED. And so that's just not ED, it's talking about out there as well. What community services are out there. So need for new visions that recognise the reach, complexity, and look at that seamless service. Break down those silos. Those silos are not helpful. How many have silos in their ED? I say it all the time. There's silos. You want to refer to social work. Social work says, I won't see them because they need to... 30 minutes left. They need to see mental health first. Oh, they don't need to see mental health first because it's just social work. But anyway, we have to see them, which extends that person's stay. Development of wraparound services, I'll be quick. Even with the broad systemic transformations, ED will sometimes always be the front door. You're not going to avoid it. No matter what we put in place, it will always happen. And the need for ED to come on board and have clear roles for mental health crisis and a strong psychiatric leadership within the ED. You must be able to manage the vulnerable populations. Child and youth is becoming huge in ED, absolutely huge. And I'm seeing as a co-responder, the neurodiversity that I get called out to is massive. I mean, my private background is neurodiversity. It's massive out there. But these families have nowhere else to go. All governments need to commit for the accountability. So it's here, the governments need to commit. The report's there, they have to commit to this. We need to look at the roles, skills, training to ensure that common occurrence of mental health conditions are understood in all healthcare settings. That's part of this, at the Emergency Services Conference, my push for mental health, because it's there. Whether it's ED, whether it's a surgical ward, whether you're in a GP land, it's there. Patients who have experienced trauma report distress, so we need to look at that. How do we link with that? How do we stop this re-traumatisation? And I put that link there if you want to look at the Commission report. It's there if you want to take a quick photo, or it will be on the slides if they get sent out. It's a really interesting read. And from an ED perspective, because I work it and I work along QAS, very interesting. And I'm amazed that we haven't been pushed more to read it as clinicians. So I'll get on to the talk, which was my talk, which is the pre-implementation of why we put in place a co-responder program on the Gold Coast. So we recognise there has been increasing demand for provision of mental health care in ED and emergency services. It was there. It was beckoning to be helped. This led to establishing a collaborative relationship between Gold Coast Mental Health and Queensland Police and Queensland Ambulance. So our Queensland Police co-responder model has been established for 5 years. I also do a bit of the police co-responder as well. Because of that success and keeping out 64% of patients from ED that would normally come in 2018, it drew us to really develop the QAS model. Just flick that, that's just our, and MOUs, flick past that. Tri-agency agreement, we all know it. It was about bringing all the services together. You had to have all the services on board. So it was about guiding principles. We had to have a memorandum of understanding. We had to have governance. We had to have our mental health intervention coordinator officers, and we had to have operational liaison committee around that. We had to have a principal agency role and responsibility and legislation and resolution of services. We had to have frameworks for joint interaction and an operational framework. So the ED avoidance model was about improving the consumer experience in ED. It was improved mental health patient flow if they came to ED. And it was about ED avoidance strategies and co-design models through collaborative relationships. So, as I said, we had our QAS and our QPS. So the initial funding came in 2019. I'm going to speak more for QAS, but we, through the EB10 nurses and midwifery innovation, we got a submission for 12 months. So we put it in place. In 2020, we were giving permanent funding from Care for Queensland strategy for 1 crew. And then 2022, we got further funding from Better Care Together, and that added the 2nd crew. And now there's been a further expansion from Putting Patients First funding, which will make us up to 3 crews, and we're currently recruiting for that. That's just little photos, flick through. So the co-responder program. So it's a collaborative relationship with QAS, QPS and mental health. The model operates by situating a senior mental health clinician with police and with QAS. and it's mainly for mental health crises. There's slight variation between the models, and I'll get to that in a minute. So QAS, the co-responder is a primary response unit where the mental health clinician and paramedic attend 000 calls. Those people from Queensland, do you have co-responder in your area? Yeah? Do you find it effective? Yeah. So on the Gold Coast, there's two, and as I said, we're recruiting for that third one now. And it's a nursing-based position. It has to be nursing-based. Because if there's an emergency in the area and we're the closest crew, we go. So we will have to, if it's somebody's dying and needs CPR, then the poor mental health clinician is going, oh my God. So there's lots of training for us to re-uptake our training in, emergency. So we work 7 evenings per week, 10-hour shifts. So QAS is from 12 till 10. We start work at the hospital and the QAS pick us up. So we now have set up a WhatsApp group for them to say, I'm here, who's on, who's not. We've now had such an interest from our QAS that we've had huge expression of interest and lots of QAS coming on board to learn the position. We work in the low acuity, so LaRue, everybody knows the LaRue compared to Bravo, yeah? So we have, I call it the silver bullet. So if somebody needs resus, it's not us. Yeah, we don't have a bed. We don't have the ability to respond. And it's 3 pathways. So self-dispatch, we'll see all the jobs and we will attach ourselves if we know the person, if we think it's us. I'll definitely attach myself to that. QS comms can attach us. The QS crew on scene can request our attendance. At times we've also done phone assessments. If we're busy on one assessment, we can't get to them. Definitely, if we have the ability, we'll speak to the patient, try and set up some safety so they still don't need to be brought in, and we'll follow up with that person. We have the ability to provide telehealth and dedicated smart devices, which we all need. QPS, so I also do that at times. So again, it's 000 calls. There's one QPS co-responder. 5 days a week, Wednesday to Sunday. It's a later shift, so from 2 to midnight. It was initially nursing, it's now changed to multidisciplinary. At times I do have some concerns because often police are asking for a medical knowledge of what needs to happen, and I think you do need a medical response, but at the moment it's open. So if we look at the logistics, QPS, I'll be quick, it's 5 evenings per week, 10-hour shifts. The police comes in an undercover car, they pick the co-responder up, and we go out. We look at all the police jobs. We look at, often there's people we know, and we go, ideally we're meant to have a crew go out that say it's safe. Unlike QAS, we go out as a first responder. I think that came about when there's been some very hairy events, but initial crew has to say it's safe to bring the mental health clinician in. It's rotating QPS officers, which is great because those officers have an interest in mental health. They then take what they've learning on scene back to their field where they're normally on their normal, field work as a police officer. Yep. So there's a bit of a difference. So as I said, QPS is secondary response, QAS is the primary response. The expectation for QAS is to attend priority medical jobs as well. So if we're the closest ambulance, you've got a mental health clinician administering CPR. But we have upskilled, and we had to upskill, which is what we're saying to ED. You need to upskill around trauma. As the mental health co-responder, we've had to upskill. I've been drawing up morph on the side of sidewalks in Surface Paradise. I haven't drawn up morph in years. Or, doing CPR. We do our basic little, on the dummy. Much different, as you guys know, when you've got a real person. So the co-responder has to be upskilled. Yep. So we can go past that. So the inclusion criteria is that they have to be able to respond. The exclusion, look, we've pushed that at times on Gold Coast. So if we know the person, they're intoxicated, but we know them, and there's no other job that needs us, we'll go out. We'll assess and say they don't need to be brought in. I know the person. They just need to sober up, leave them at home, or we'll ring their team. Acute behavioural disturbance or aggression, again, if we know the patient and we can de-escalate, we'll go out and de-escalate, absolutely, because they respond better to us, rather than the need for drop, being sedated, brought into ED. And again, if they're medically unfit, yeah, absolutely, we can't do an assessment. I might start the assessment and say when they're medically cleared, they need further review. So we do on-site clinical assessment and triage. We do have several support options available. So on the Gold Coast, instead of ED, the co-responder can admit to our crisis stabilisation unit, which we'll talk briefly about. They can't refuse our admissions, unless it's like we're dodgy and we're trying to push something and they go, oh, that's a bit dodgy. And they are extending their inclusion criteria. Advice on the safest transport modalities, we'll definitely give that advice. Often I'll go in the Bravo crew if I know the patient. Rather than sedation, if I can de-escalate that person, I'll sit with that person. And I become the ambulance officer in the back. So we have timely assessment, intervention and treatment for crisis escalation in the community. We reduce the need for attending emergency department, and we have a seamless entry to public mental health, so we can refer directly to our community mental health teams. We don't need to bring it back. We refer. We also have reduced use of restrictive practices and improved experience of outcomes for consumers and experience of the mental health crisis, and improved interagency collaboration. There's also that timely release of the first responder, which puts QAS back on the road a lot quicker. Those ones that are ramping, we can get them back out there a lot quicker, as well as QPS. So at this stage on the Gold Coast, we have up to 3 co-responders, and as I said, we are recruiting for the 3rd QAS. So we have 1 police, 2, and we'll eventually have 3 QAS on a late shift. It's critical these clinicians will liaise with one another, will text each other. I'm going to the job in Mermaid, or I'm doing the job in Ormo. We don't want overlap. What's the point of overlap? Oh my God, 15 minutes, okay. The co-responder also, yep, okay. We've previously presented on QPS, co-responder results. We also do, and I will just skip through that, a lot of education to police and ambulance. So we go out and also universities to those studying paramedicine. We'll just skip through the data because it comes through. So just stop on that pie chart for a minute. So it's a visual representation. So if we look at, so the green is past, people that have past contact with mental health. So the blue is people that have had no previous mental health that we go out to, and the little grey areas, those that are currently under mental health. Yeah, skip through that. You can all link, I think, to this data because, yeah. Okay, so a key focus for the co-responder was ensuring at least restrictive and recovery-based approach. The infograph represents a key goal that over 70% of consumers seen by the co-responder were voluntary in its inception. If we can keep them voluntary, we keep them voluntary. In the past, 69% compared to when we were involved were transported to ED under the Public Health Act in Queensland. So on average, paramedics would have transported 60% of those consumers seen if they'd not attended with the co-responder. So that's massive. That's a large percentage that don't come to ED at the Gold Coast. Yeah, skip that. Skip that, Jim. We'll just skip through most of this data. So feedback. So we do get a lot of feedback, and it's lovely. We get lots of emails sent in to us. So this is one. The mental health clinician and paramedic were amazing in an awful time for us, and we have changed the names here. Their knowledge, ability to build rapport with Bella and us quickly, their compassion will always stay with me as a beautiful part of a really hard situation. Please pass this on to them, and please recognise them for their exemplary service to the community. Another one was mental health clinician was able to calmly talk through what was happening and genuinely show that they cared for the situation. So again, going back to that trauma-informed model. The reassurance I was able to get help with that daunting process of going to hospital has greatly aided in my recovery. And then that last one, the mental health clinician and paramedic were amazing, and they saved me from my mental anguish that day. I'm so grateful that they'd come to see me, and not one negative comment about these ladies. So police, we can skip through that, I can just tell you, police and ambulance are saying lots of positives. So especially from the paramedics, and I love to see when the LaRue officers are on without us, they actually report that they identify that they're upskilled, that they can go to a mental health patient without the co-responder and feel that they can make a difference. I actually had a new paramedic with me in a situation, and it was a dicey situation. He said normally that person we would have drop drawn up, we would have police, we would have dragged her down, sedated her and brought her in. We managed to I went back to the ED, I got medication, we brought it back, she was linked with community mental health team, she didn't have to come in. ED saw it as they gave me 4 days worth of Valium and 4 days worth of Abilify, and the psych reg gave scripts. They avoided a huge presentation because normally they cleared out that DV refuge because they were ready for a big takedown. So we're able to avoid that, and that woman is now engaged and back on medication. So the co-respondent needs to have advanced practice. We just don't take anybody in the role. They need to have their head over all aspects of mental health as well as some medical knowledge. It requires critical thinking, complex decision making in a largely autonomous realm. We're accountable for the decisions we make. We can call a consultant, but it's on us. So we make the call, we take the risk on board. Clinicians are required to attend all emergency mental health crises for a variety of populations, meaning we need to have that broad knowledge. I've seen a 6-year-old up to a 100-year-old. That's what we see out there. I think you can skip through that. So our treatment options, the primary function is to prove the consumer's journey. A major component of this is consideration of the most suitable pathway. I've gone out to people that are in withdrawal and I've rang the GP. I've got an e-script sent from the GP to start some Valium. I've linked them with the AOD service, whichever one I think is equivalent. They don't need to come to ED to do that. There's lots of other examples I could give for that. So on the Gold Coast, we're fortunate to have a variety of options. So we have ED, which we do try to avoid. We have our crisis stabilisation unit, which again is expanding in their inclusion criteria. And we can refer directly to community mental health teams. They don't need to see a reg. We can do that. So generally emergency departments are utilised when there's acute medical concerns, the consumer is at risk to themselves or others, and we can't safety plan, or they're so acutely intoxicated they just need to sober up. We'll still do an assessment, and as Sarah might note, we'll often ring and say, look, this person just needs to sober up. Once they're sober, link them with AODs, discharge them because our community mental health team is going to see them. Yep. So I'll ask Sarah to speak in a minute about how we can decrease. Often I go straight to the consultant. I might get the consultant. Like one time, Robina was unable to take the patient because they were too acutely disturbed. I was able to ring a consultant, get the phone call to give some olanzapine, rushed into Robina, gave some medication, and we then furthered our journey up to Gold Coast with a police officer helping us to keep the person de-escalated for safety. We aim to support in their own environment. Yep. So our CSU, I'll just do a brief. We set up our crisis stabilisation unit on the Gold Coast, and the aim was it is an area outside of ED where people can go that need a mental health assessment that don't need ED input. And we've really tried to push on that. So initially they were really quite restrictive what they would take. They can't refuse from us. I'll take intoxicated people there. I took one guy that had taken 28 grams of uncut coke over a 4-day period. He was he was actually earning a lot as a, what do you call people that do poker dealing? Ripier, something? Anyway, he was earning 10 grand a game. Better than what I earned. But CSU took him. He just twitched for hours and hours, sleep intervene, give some medication. Yes, he was intoxicated. Yes, he'd taken a shitload of coke. He will recover. He's not going to need ED for that. So I'm just going to give a few, and I know that time's limited, for a few just clinical vignettes. So this person's well known. So a 16-year-old, he's in NDIS housing under full-time care. Sarah probably knows this person. So the carer's called 000. He was on the roof, multi-storey building, threatening harm. So, of course, we had the fireys out, QPS, QAS, it was full on. We know him. We attended. We were able to talk him down off the roof. We were able to send the fireys away, police away, and we're able to keep him at home. Often, if we have to bring him in, we do, but we try and keep him at home because often ED is counterproductive for these kids. Next one, Charles. Another one was a 27-year-old male, home alone. He called 000. He was psychotic. We responded as the primary response. So we didn't need another crew to attend. We went out. So he was agitated, he was psychotic, he'd been using steroids and other substances. We de-escalated, we engaged him. He expressed some concerns about being triggered in ED. So we're able to coordinate going straight to the resus room. So we ring to the likes of Sarah's and say, we're coming in, this is the situation, can we go straight to resus? Yep, and it worked. We avoided the huge aggression that we would normally get with that patient. And this is another one, and it's close to home. This was a health professional. So she was 40. She's quite depressed and quite suicidal. The family called. They felt her mental state was deteriorating and a change in her risk profile. So we attended. She was quite concerned about being assessed by her colleagues. Understandably, nobody wants to be brought in those situations and be assessed by their colleagues. So we were able to organise to go to our CSU, so she didn't have to be assessed by her colleagues that she works with, and we maintained some safety planning while maintaining her privacy. And just one more, which was that DV one, which I think is an important one. So she's schizoaffective, so in the past, huge history of aggression when unwell. So she'd been offered medication. DV shelter had cleared out the whole DV in preparation that we would have to sedate, restrain and transport. As we went up, because we wear an ambulance uniform, she went, here we fucking go. So it was about just forming an engagement with her, and she allowed me in to do the assessment, and eventually she allowed me to go back to the hospital, start medication. I did put her under the Mental Health Act. I did then come back, deliver the medication, and the mental health team saw her in the community. That would have normally have been a huge takedown, sedated, and re-traumatised that patient, and she's now currently well. So the unexpected opportunities is that collaborative relationship that have been developed with emergency services. I love hearing the AMBOs I work with. Whenever I do an MSc, they do it with me, and I love hearing how their knowledge has developed, because they can rattle it off in our language now. And same for the medical language, and I still say I need to update myself more on the medical bits. But it's that collaboration. You know, if they know we're on board, they will often ring and ask for the correspondent to come out. The education we've delivered, again to QAS, the peer support workers. QPS, we deliver a lot of education. Also to the ED, we've given education, and also, as I said earlier, to universities around the paramedicine course. So police correspondent providing education, as I said, to police. We often specialise with our police response team, our Queensland Fixed Threat Assessment team, and our vulnerable persons unit, which is the police. So they'll often send us on jobs. I must say one job that they sent us on was very hairy, and the woman nearly got shot because she came at us with a knife, and she took 2 tasers to put her down. But anyway, we ended up getting her admitted and we're all safe. But in saying that, there was another case where I was attending with QAS and QPS and was nearly set alight. And this is the things we need to fix. So we're exposed to fumes because he was putting some form of liquid over us. As we barged in the door, he tried to set fire to a butane canister, threw it at us, it didn't work. He put the liquid on the floor and the whole unit at the ridges was alight. So we're trying to put out the fire, contain him, he was tasered. Ambulance directed us to the private sector for medical clearance. Fine for the ambulance officer, but this is learning progress. I'm still billed, which I had to pay yesterday, $396 for medical clearance to get back out in the field. So ambulance is saying not my issue, Queensland Health is saying not my issue. So they're things we need to fix because it's the mental health clinician that then pays for medical clearance around something that wasn't our fault. These are outcomes. We didn't plan for these, unexpected opportunities, and there's many more. And I think we'll constantly be finding many more opportunities in the future. So the summary is development of collaborative relationships with emergency services, the implementation of mental health clinicians working alongside emergency services, the utilisation of Gold Coast Health Services from ED, CSU to referral to community mental health teams, and the take-home points. So as we said in the beginning, if we have caused any trauma from what we have to nominate it, please seek us out at the end if you want to talk about something. But we always say, remember bias. We all have it. It's a human function. We all have bias. Even our own mental health teams. You know, at times when I look at mental health and I look at our young junior nurses who are too scared to speak up, when there's a senior nurse really stigmatising against mental health. I think they're things we need to, remember too. How do we make a difference in that sphere? Need for alternative practices and places to see mental health. The overshadowing, which again is my big bugbear. It's huge overshadowing, but there's another talk in itself, and I know I'm running out of time. But often mental health patients, the overshadowing of their physical concerns are not met. We need to look from a trauma-informed lens and cultural safety, and again, that's a great talk, and I don't know if anybody would be interested in learning about trauma-informed care. Do you want to put up your hand if that's something you need help with? No one needs help with trauma-informed care? So you all know how to do trauma-informed care? No. So do you need help within trauma-informed care is what I'm asking? Yep, so put up your hand if you're saying yes, that's what I'm asking. Yeah, okay, thank you. And look, even our own staff, and I look at some of our staff and they are not operating from a trauma-informed lens. And we're not saying anybody's not operating to where they should be. We're just saying that we need to have more capacity to know what trauma-informed care is. Innovation, thinking outside the square, blue sky thinking. Think how you want your family member to be treated. That's what I always think. And you're awesome. You all know what you're doing. You're doing a great job, so you just need to keep going. And I think, I put this little song on because I like songs. But do you have any questions or any questions for Sarah maybe before we end? Because I know there's another talk after me. Did anybody find that helpful? Yeah?
In Sydney, and that is exactly the same as Brisbane and the Gold Coast and Sunshine Coast. And we're lucky enough we've got one now in Toowoomba. Yep. But what our problem is that we're finding with work is our rural placements. There's a real increase in mental health actually drifting out to the western towns. Yep. And we just don't have the facilities, or the hospital don't have the facilities to cater for that. And that's with the rental crisis, and that there's cheaper rent out there. And it's the lower socioeconomic status that is moving, which increase in mental health, and it's causing a real issue because the closest facility is Toowoomba, so yep. And no plane will fly them.
Absolutely. And I think when we spoke in Queenstown, there was a paramedic before us that spoke around BARS, and she was awesome, and we did have lots of discussion around that. Definitely, I think we need to roll out this program all over and have the ability to have support in rural. Absolutely.
Thanks. Can I just extend that? So I've just finished a 25-year stint in rural general practice as a rural GP in South Australia, and I'll support what you said. The mental health workload is significantly more than when I started in the mid-90s, as it is everywhere. It's a different scale. We're both the GP practice and the ED, so we have a vested interest in getting this right. But what I would say is we do lack that support. It's really hard going, and I think your initiative is excellent. I don't think it's in metropolitan Adelaide. I could be wrong there, but certainly where I've worked, we don't have anything like this, and well done. It's great.
Thank you. And I do agree, it's needed. And all I can say, I used to work rural in my younger days, and definitely we need more support. The only thing, we're trying to roll out our credentialing mental health services. I'm not sure if you had access to a credentialed mental health, but that's how I work privately as a credentialed mental health. So you can employ a credentialed mental health attached to your practice, which then can help facilitate some care. But so we only have, which is frustrating to me. So yes, many years ago, when I started in 2008 as the first credentialed mental health nurse, we had unlimited sessions. Yeah. So that changed much to everybody's despair when I think there was lots of, and I hope there's no psychologists here, psychologists thought that mental health clinicians were taking away their business. So what we tried to say is we're not. We're just we can give daily support to that person and build up their coping mechanisms so you can do the work. So when I work in private practice, I'm allowed 5 allied health sessions. After that, they have to pay privately, which is a real pity.
I agree. It was one of the best initiatives through Medicare, and it's a real shame that it's gone. It was super. So yeah, thanks for doing it.
We are pushing it back there to the college. So yeah.
All right, unfortunately, we are going to have to call it there, but I'm sure Kim, Tahlia and Amanda will be hanging around, so please make sure you come up and have a chat. In previous conferences, they've seen some great link-ins and some people have actually gone back and started sort of looking at how this can be started in their own services. So it's exciting stuff, and thank you for sharing with us. So let's hear it for Kim, Amanda and Tahlia.
Oh, now we need to click on the music. Wah, wah.
So let's just take a 5-minute break, just a short one. There's still plenty of food out there, so yeah, grab some food on a plate, come back in, and we'll get going shortly. And we'll play the song for you.
Closing time, open all the doors and let you out into the world. Closing time, turn all of the lights on over every boy and every girl. Closing time, one last call for alcohol, so finish your whiskey or beer. Closing time, you don't have to go home, but you can't stay here. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. Closing time, time for you to go out to the places you will be from. Closing time, this room won't be open till your brothers or your sisters come. So gather up your jackets, move it to the exits. I hope you have found a friend. Closing time, every new beginning comes from some other beginning's end. Yeah, I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. Closing time, time for you to go out to the places you will be from. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me Closing time, every new beginning comes from some other beginning's end.
No. Got my shoes here. Put my thongs back on. Get out of this dress and I'll be.
got the
you've got the glow. Fuck.
we've got the photo competition first, so
Oh,
you
no,
can
great.
put your feet up. Okay, who's ready to win some prizes? No one. No one wants a prize. You guys all know the rules now. The loudest cheer will get, the loudest 3 cheers really is going to get the prizes. So we have Dan Murphy vouchers, Rebel Sports vouchers, as well as 2 EMS t-shirts. The vouchers are very kindly sponsored by Everest Wealth and Emergency Fit. So if we could flick over to the PowerPoint, let's start things off with a bang. Wait for it. What do you reckon? First EMS Bali tattoo. We were concerned that they were real. Turns out they are temporary. So we did feel this sense of responsibility for a while. Next up, surfing down at the beach. It's quite an artistic photo, that one. I like it. Oh, another ATV one. That's pretty impressive. Oh, from the opening party. Looks like someone's got a drone up. Oh, that's a nice one. Where was your cheer, Dimmy? I thought you'd be cheering the loudest. Ah. She does have a bottle on her head. I didn't even see that. Ah. Well, I look forward to seeing you try to balance a bottle on your head doing the Macarena later tonight. A few more to go. Another elephant one. Oh, jeez. Oh, here we go. There's even someone in there. It's like a Where's Wally? Pick the guy. I don't know if it's organised, to be honest, but there we go. Oh, that's pretty good. Oh, that's nice. Sunrise out the volcano. Oh, I think that one's leading so far on strawberry daiquiri. All right, I think we've got our winner, which is the volcano sunrise. Yep. I think we've got to give some t-shirts for the 2 girls that got the tattoos. And what do we reckon? As the surfing one? No? Which one? That one? All right, and whoever posted that one. So that's all our prizes. So once again, a big thank you to Emergency Fit and also Everest Wealth for donating those ones for us this week. If you were lucky enough to win a prize, please come down and see either Dylan or myself at the end of the session and we'll sort you out there. Now, for the one that we've all been waiting for, I'm going to call up Locum Life because they're going to draw the lucky winner of our iPad 10. So let's hear it for Locum Life.
G'day guys, hope you had a good week. I can tell you've been busy conferencing really hard by those photos. We're Locum Life, a medical recruitment agency. My name is Niels, this is my colleague Delphine, and we're here to announce the winner of the iPad giveaway, which is in this letter. And the winner is...
Anan Santich.
Oh, Anan, our presenter. Come on up, Anan. We've got mutiny in the wings over here.
There you go. Congratulations.
Well done, Anan.
There is an iPad in there.
Not just a prop.
Lovely.
Brilliant. Well done, Anan. And let's hear it for Locum Life, who've been great supporters this week of the conference. Okay, so to bring us home, I'd like to welcome back up onto the stage Cherie and Jacqueline, who are going to be doing our final presentation for us. So let's make a nice, loud round of applause for the final time, Cherie and Jacqueline.
Oh, that's going to be a challenge.
I'm sorry.
Everyone, can you hear me? Down the back? Cool. Thanks heaps for turning up. It's been a great week. Everyone pumped and ready to go home? Okay, so today we are going to have a look, and it's basic limb assessment and injuries common that we see out in the communities, first responders, your paramedics, your triage nurses, ED, okay? And I need a few crash test dummies, and I will be calling on the audience for participation, okay? You've been pre-warned, so if you want to run out the door now, go. Okie dokie, so here we go. So, essentially very simple definition between sprain and strain, and it's exactly the same, okay? It's a wrench or twist of the ligament, soft tissue, muscles, cartilage around your bony skeleton. Okie dokie. And so treatment is the same. Can anyone tell me what treatment is for sprain and strain without me dragging it out of you? Perfect. Rice. Don't forget that analgesia. Okay.
There is a slight difference between a sprain and a strain.
Yeah.
A sprain is involving the ligaments, whereas a strain is involving the muscle or the muscular tendinous junction. So but the treatment, as Cherie said, is the same. There is a slight pathological difference between the two.
I keep on forgetting this. Let's go on to the next, please. I don't like this. We got it. Yeah. Okay. So, how many know if none of the nomenclature that you use in your ED or you've been taught, fractured, broken, cracked, any other little things for a fractured, broken bone that you can come up with? Anyone? Okie dokie. So a fracture is either a partial or a complete break of the bone. There's two definitions in the ED, open, closed. So open is a wound over the fracture. Sometimes you can't tell whether the wound is actually communicating to the bone, but if you do a really good history, you should be able to know, okay? Simple fracture, closed, simple fracture, interchangeable. And there's different types, lots and lots of different names. So avulsion, Salter-Harris, Montejo, Smith's, base of fifth, green stick. Now the other name for green stick these days, technical term, buckle. And NOF, we all know what that is, and a comminuted fracture. And they're very, very serious, I think, the comminuted fractures more than anything. Go for it. Yeah.
And you've just got to love it. You know, you get a patient, you assess them, you do their x-ray and you come back and you say, I'm really sorry, you know, you've got a fracture through your tibia, and they're like, oh, thank God it's not broken. It's just like, it's the same thing. We've all heard that, haven't we? You know, they're so relieved that it's not broken.
But fracture means broken. So then you're on to your history, and our history, your mechanism of injury, the story, so important. Okay, how did the injury occur? What activity were you doing? Did you fall down the stairs? You know, is your injury a distracting injury and you've actually had a loss of consciousness that you don't know about? So mechanism of injury, the story that they know or someone has witnessed is really important, okay? Any first aid at the time? How many have you heard the story, did it on the netball court? And how long ago was that? 15 minutes ago. And it's interesting. Function since the injury, that's really, really important, because if they're walking with a limp or they're non-weight bearing, influences your decision tree by, you know, what their triage number can be, okay? Any analgesia, have they riced, any previous injury to the same area? Have they had an ORIF? Have they had a previous fracture? And this is non-union from a fall. Okay, big, big, big. Very, very simple. I love the keep it simple principle. I love KISS. So let's have a look. Is the skin intact? Bruising, swelling, and deformity. What does it look like? Have a look. You've got another limb on the other side. Do the comparison, because we're all individuals and we'll all have little idiosyncrasies for our own body type, yeah? So have a look at the other limb. So if it's on your right, look at the left, see if there's any noticeable differences.
Particularly, sometimes people come in with wrist injuries and they go, my bone's sticking out here, you know, the ulna. And you're like, yeah, have a look on the other side. It's been like that your entire life. They've just, it's true. Or this is sticking out here. And it's like, that's your normal anatomy. You know, so it's really good if you can show them their other arm and say, yeah, that's supposed to look like that.
Okay. Next. Please tell me the right slow. We need...
No,
Oh, yeah, good. No, food. We need feel. Not move. Feel.
Sorry, guys. She's very fussy with her slides. Here we go.
So feel. If they will let you, you can actually feel the deformity, especially on the clavicle. Palpate it. So palpate the clavicle. Do the uninjured side first so you know what normal is, yeah? If you can recognise normal, you can recognise abnormal. So get to know your normal down pat. It's fine if you don't know what the abnormality is, but you can differentiate between normal and abnormal. And then if you don't know what the abnormality is, you can escalate it to your seniors. So for me, the basic principle in any injury, know what normal is. The same with childhood development and age-appropriate growth. You know, it's those basic things. It's the same with, you know, cardiovascular. If you know sinus rhythm, you know an arrhythmia. Doesn't matter what it is, as long as you recognise abnormal. Does that make sense? Cool. Crepitus, we all know what crepitus is. Have a feel in that crunchy, creepy feeling. For me, I know my knees are crepitus. Old ladies' house-made knees, yeah.
Especially after the waterfalls.
And if you can feel it on yourself, you can recognise it elsewhere. Once you feel, you know, you felt that squeaky tendinitis wrist, it's unmistakable. You're never going to miss that tendinitis, squeaky, painful feel. And they won't like you touching it either. And your patient doesn't want to move it either. Yep. Tension. So how many of you palpate an elbow and you immediately know from the swelling and the feel of it that that's a supracondylar? Yeah? A few of us? Cool. And then pain. Get your kids, especially, one finger and get them to point to the pain, because most kids will go all over. And then you say, one finger, point specifically to where the pain is. And most of them can do it. Yeah? Cool.
We've got a consultant that's really cranky if with a kid you can't localise the pain, so you order a limb x-ray. You go shoulder to fingers or hip to feet, and he's like, just x-ray the bit, and it's like, I couldn't localise it. It's so hard with kids.
Okie dokie, let's go on to the next. And move. If you can passively move the joint, the limb, without them causing pain, then you're looking at your function. And then you can specifically get to the area of the pain, yeah? And you always assess distally to the injury and you assess proximally above the injury, yeah? Because this distracting injury that you've had a backwards push and there's an obvious deformity of the radius is distracting you because it's so painful. But then you may have a fractured, you know, distal humerus. you may have a dislocated shoulder, but the pain in your wrist is overriding that other injury. So make sure you always examine distally and proximally to where their localised pain is.
So the slide on the left is actually one of my patients. I get the good ones. A very young teacher who was at the school. So this is where it's really important to get your history. And a whiteboard had started full and he'd gone and grabbed it. So he came in looking pretty much like this, no real function in his arm. His bicep tendon was completely bunched up. So just from that history, I'm straight away going for a soft tissue injury. It's unlikely that he's broken, dislocated anything, but it does look really deformed. But you can palpate that. You can test the function of the limb, and you can, you're pretty much convinced what it is, which it was a biceps tendon rupture. Which opposed to the other one, where you've got deformity. You're going to have swelling and deformity, but your history on this other X-ray is going to be somewhat different. They've probably fallen onto it, or they've, had a blunt injury. So it's very important. There's no point X-raying that biceps rupture. There's not going to be a bony injury. So, yeah.
Just some more interesting x-rays that I've seen over the years, and some of them are quite obvious. On the ankle, like the AP view, there's really, unless you've got a really good x-ray screen, you may miss that fracture. But on the oblique view, you've got a medial malleolus. And because it's intra-articular, it needs to have a below-knee cast back slab, be non-weight bearing, and it needs to go to fracture clinic within 7 to 10 days. That needs to be repaired, okay, because it's intra-articular, it's affecting the syndesmosis, the mortise. Okie dokie. The wrist, little old lady, backwards push, rammed and ruined radius. That's dorsally angulated. So that one needs a pull, reduction in ED. You could probably get away with Entonox and a radial block, so regional anaesthesia. With kids, when they've got a rammed and ruined Salter Harris, in the ED, Jacqueline and I often do Entonox and intranasal fentanyl, and it works a treat. If you can talk your kids through it and talk the parents, and if you've got the parents on side, the parents will convince their kids that this will work for them. And your parents are your absolute, agent for convincing their kids that this is what needs to happen. If you've got a really good parent who's going, no, you're going to be fine, this is going to be lovely, you're not going to have much pain, it'll be all over in 5 minutes. Get your parents on side, talk them through it. Okay, it'll be much easier.
And really good pain relief for the kids. Yeah. I like to have my kids high as kites. Happy, laughing,
giggling.
Completely off their chops. You can literally do anything, they don't care. So I love the Entonox for that.
And you pre them, you prep them, get them to puff away on the Entonox before you do anything. So they're already laughing, giggling, and then you give them the intranasal fentanyl. You wait for a few minutes, set up your plastering and reduce it. Yep. This kid here, he was another patient of mine, 18-year-old, just started his roof carpentry apprenticeship, and his first day on the job, shot himself with a nail gun into his femur. And no pain. He was fine. And he was like, can't you just pull it out here? And he said, get a big pair of pliers and just pull it out. And I was like, no, we're going to x-ray this first, because if it's soft tissue, we're still not going to pull it out, but it will be a lot better outcome. But yeah, it actually went in, shiver me timbers. Did I do that?
Yeah. I was ready for you.
Sorry. So yeah, he just went straight to ortho theatre and they removed it. But it was 0.5 centimetre into his femur. And there was no way we were going to get that out. He would have had a bleed as well. They would have controlled that in theatre. You know, he's got to have all the bits and bobs that's going to prevent him from having a pulmonary embolus. But yeah, he was no pain, sort of like this, into ED. And that's what he had in his leg.
I would be x-raying like anybody that shoots themselves with like nail guns and things like that. It's very tempting to just go ahead and just pull it out, but it's always really good, you know, to have an x-ray, see if there's any bone or joint involvement. And also, like, with this, you'd be testing the function, because if they've gone through their patella tendon, that needs a washout. That's not just a pull out, give it a bit of a, you know, irrigation. If it's through that patella tendon, and you're going to know that as soon as you test their function, it's going to hurt. So yeah, it's really important that you kind of always think about your underlying anatomy. What's there? What could they potentially have injured?
You can go on to the next one. So your first aid, you know, this is out pre-ED, and you hopefully, you know, most of your first responders or first aiders, that wherever they are and before ambulance, hopefully they will do this. Position of comfort, you know, ice, elevate, support it, splint it. Different types of splints out there. There's so many these days. The variety is huge. I've even seen air splints in a first aid station on a netball court. And I don't think ED at Armidale has air splints. Okie dokie. And don't remove, replace. There are exceptions to the rule, but 9 times out of 10, don't remove the foreign bodies. Don't remove the boot when you see all this blood pouring out of it. You know, support it, reduce the movement, get them to a definitive care as soon as you possibly can. Any questions about this slide in particular? No? Anyone out here in the audience who works remote, rural? Yeah, a few of you. Yeah, a nursing clinic. Anyone out there who doesn't have access to x-rays? Yeah. It's amazing, isn't it? And you just have to go with what you got and talk to your RFDS, the trauma line that you have. Do you have access to the trauma line, Royal Perth Trauma Line, and at a trauma line where you are that puts you straight through to an ED consultant or an ED registrar? Yeah. And how many of you have telehealth? So you can actually take the camera to the patient, and whoever's you're discussing the case with can actually see the patient and see what you're talking about. Makes a huge difference. When telehealth came into Western Australia, I was working in the bush at a tiny little nursing post called Jerramungup, which is in between Albany and Esperance, and it made the world of difference to my practice. I just felt so more in a comfort zone, knowing that, you know, visibly someone else could look at my patients. Okie dokie, let's go on to the next one and we'll get through this. Yep. So Ottawa ankle rules. How many of you refer to this? Know it, off by heart, blind, can do it in your sleep. And I want a crash test dummy, please. Volunteer from the audience. And I think because it's the Ottawa ankle rules, have we still got a visitor here from Canada? And he's from Vancouver, I believe.
We've got 2 visitors from Canada, so
so
we might
let's have both
let's
of
have
you
both
up
of
here.
them up here. Seeing as these are Ottawa rules, they should know them inside out. Where's our other visitor from Canada? Come on up.
Come on up. Come and grab a seat. Thank you for volunteering. You didn't really have much choice, did you? And I didn't warn you, but, you know, fair enough. So, from the audience, what are the 5 major points? Without looking at the slide. Get rid of that.
I think you're too late. They've all looked. They've all looked.
But essentially, there's your 5 points, okay? So your medial, lateral malleolus, your base of fifth, your navicular, yeah, and your posterior.
So Cherie's just going to show you how she would do that on a patient.
Am I going to do that?
You're going to do it.
I thought you were going to do that.
No, you're doing all the work today.
But there's 2.
No, I'm doing the knees.
Oh, okay. No, there's somebody else we need for the knee.
No. Ankle, knee.
We agreed on something and she changes the rules on me. Okay.
You have. That's okay.
Okay, so you need to remove your shoe, young lad. So, medial malleolus, yep.
So you're just going to feel along the posterior lip of either malleolus there. Two other spots you'd look at. They've come in with an inversion injury. So where is another place that you would palpate and think there may be an injury?
Sorry?
Absolutely.
And what is that fibular head? What are you looking for? It's got a name, and it was named after a famous doctor in an area where they were skiing, and it was called Maisonneuve. So you guys probably know it as proximal tib fib, yeah? So squeeze the proximal tib fib, and if they've got pain up there, you need to do it, because you might not have anything in the ankle fracture-wise, but your degree of suspicion is telling you something else is going on. So there's disruption of that symptomotic sheath that runs up in between your tibia and your fibula, and it explodes out of the fibular head, and you'll get a fracture at the fibular head. Okay?
Where else could you have a fracture with that kind of involved inversion, rolling injury? So we've got the knee, we've got the ankle, base of fifth metatarsals. So often we front load our patients in ED, and the nurse will come in and they'll say, oh, the patient's rolled their ankle, can I get an ankle x-ray? I actually won't sign off on an ankle x-ray unless they can tell me that they've already had a good feel around the ankle, around the foot, because the amount of times, you know, by the time they get in, it's an hour, 2 hours down the track, they've had that ankle x-ray, I bring them through and they've got pain over the fifth. And then I have to send them back again, because you're not going to get enough of a view in there, you know, with an ankle x-ray. So it's really important, you know, if you've got a fracture in any area, that you're looking around as well.
Any questions about the off-right ankle rules? Happy?
So the general rule is that you don't x-ray an ankle unless they fit the Otter ankle rules. Unfortunately, in the real world, that doesn't always happen. They come in, they can't mobilise, and in all honesty, we x-ray them and they don't fit the rules.
But most of your patients that don't need these x-rays, their family or someone or Dr. Google has told them that they need an x-ray, and they won't leave your department until they get their x-ray.
Or they'll come back the next day hoping that somebody else that's on that will let them have an x-ray. So I know we shouldn't do it, but really we do. We x-ray a majority of ankles when we shouldn't be, but yeah. So that's ankles.
Thank you guys for your participation, much appreciated. No, I'm running this, get out.
What about the knee?
Are we good to go now?
Yes, you may go.
She's so bossy.
Who's bossy? Okay, so can we go on to the... Oh, and look, there's just some interesting ankle x-rays. Can you pick the fractures?
The arrow's a bit of a giveaway.
The arrows are a dead giveaway on the foreign body. The middle one, can anyone tell me? Quickly, come on. It's not rocket science. Yeah, malleolus, perfect. What about the third? Ooh, that's a ripper. That is an orthopaedic emergency because it's a dislocation, fracture, syndesmosis, mortise, complete disruption. That is an orthopaedic emergency. Okay, now we're going on to the Ottawa knee rules. And because he's a friend and he won a really good prize, Dr. Senthi, you're the winner, chicken dinner. And Jacqueline's going to do this examination. Go for it. So, Ottawa knee rules. Now, when the Ottawa knee rules came out, they say anyone over the age of 55 deserves an X-ray. Okay, but again, in the ED, how many of us X-ray knees unnecessarily? They've walked in, they've got a limp, it's really sore, they've had a sporting injury, all the rest of it. Yeah, go for it.
So I'm going to totally presume you're under 55, but if because I'm sure he is. Winner. But first off, if they're over 55, you X-ray it. Okay. Now the beauty of this is I saw Anand walk up here, so I know that he's been able to weight bear for 4 steps or more, and that's either at the time of the injury or when they come into ED. So often, they'll come in like this from the waiting room, and then you go, "Oh, good, you're weight bearing." They're going, "No, I'm not," but they are. It's just kind of like so. And then when we palpate the knee, we're going to palpate over the patella. So if they've got pain on palpation of the patella, we're going to X-ray the knee. Also, head of fibula. Okay, so if they've got pain on palpation over the head of the fibula, we're going to X-ray. And then we're going to go onto our move. So if they can flex their knee to 90 degrees, they shouldn't get an X-ray, but they will. And often, they'll come in. Sometimes knees are a little bit difficult when they first come in because they are incredibly swollen. So it's always good if you can get a little bit of elevation, get some pain relief on board. People are very reluctant to move things. But in all honesty, I see several knees every day. The majority of them do not need an X-ray. It's always soft tissue. It's a twist or something like that. Coming back again to your history. You've got to kind of piece your history together with what you're seeing, what you're feeling, and what the patient can actually do. But once again, as with ankles, we tend to X-ray the knees. But you can kind of get away with it a little bit better if they're walking. You just say, "Look, you're walking, you don't need an X-ray." So, yeah. Thanks, Anand.
Yeah, but the other thing that I do with my knee exam, and this is just a little segue to cover stuff.
He wants to know if he's allowed to go.
Oh, why do you want to run away? I don't want you to run away, Arnie.
I support X-ray releases.
Yeah, you can run away. The only ad that I do with that particular exam of the knee is if I try and get them to straight leg raise, because that often rules out your cruciate, your ACLs, your collaterals. It means that your quadriceps are working properly and their knee is stable. If they can't so you always get them to straight leg raise on their good, show them how to do it, and that they can lock their foot and lift up and use their big quadricep muscles, yeah? If they can do that on the affected limb, you're pretty secure in saying that I'm pretty happy that this is a sprain, strain, and if things don't improve within 7 to 10 days after their x-ray shows nothing, they can see their GP or they can go and see a physio for some assessment. Yeah, and the same thing applies. You're going to do their distal exam, their pedal pulses, their perfusion, their cap refill. Yep, happy with that? We're going to have to move a bit because, so you have a look at the x-rays. One's really, really obvious. That's not a bipartite patella. That's actually a fracture, yeah? The other one, and it's subtle. Can you see the tiny little, I'm going to call it a bony fragment? Fracture? Osteophyte. Have a look at your screens. We often get tricked that we think it's a fracture and it's actually an osteophyte from wear and tear and maybe an old injury, but that was actually a fracture, okay? Have a good look at your tibial plateau. It should look like a wavy, I call it an M, or some people call it a double wave. Make sure they're nice and crisp. Okie dokie, let's move on. So there's your investigations. We all know what they are, but remember, you don't need to do an MRI in the ED. In our ED, we do not do MRIs unless it's a life-threatening event and they need it, okay? So they're not going to get an MRI on their knee, they're not going to get an MRI on their ankle, they're not going to get an MRI on their elbow or shoulder, okay?
They may get a CT. There's a few injuries with your knees, like if you are really thinking that may be a tibial plateau fracture, because there's sometimes hard to see on the x-ray, then I'll get a CT, you know, and you'll often pick up a depressed fracture in the knee there. Feet, have you all heard of a Liz Frank injury? Hands up if you haven't. Okay, oh, I better tell you what it is then. So it's a twisting injury of the foot, and it was named after a surgeon in the Crimean War, Liz Frank, because we always name them after the doctors that found them. And it's kind of a pulling, twisting injury of the foot. And it was when the soldiers would get their feet caught in the stirrups on the horses, you know, and they'd get pulled and twisted at the same time. So that, you know, goes back to your mechanics of injury. Now, there's a ligament between the base of the first and the second metatarsal, your Liz Frank ligament, and that can rupture. And it can be a devastating injury for the patient if it's not picked up. And what will happen on the x-ray, you'll see widening in that area on the x-ray, you know, and then you've got when you put that together with the history, you've got a very high index of suspicion. Those ones I would CT, because they need early intervention. If you miss that injury, you send the patient away, they can actually collapse at some stage through their midfoot, and it's devastating for the patient. It's not an injury that you want to miss. If you don't have a CT available and you're just not sure, plaster them. Don't allow them to weight bear on it, okay? And then just get them off to an orthopaedic specialist somewhere where they can actually deal with it.
Okay, so let's just move along. And rice, we all know it. We all encourage it. I would love to see the first aid courses still be treated in our schools and stuff. And I don't know about other states, but Western Australia Education have really dropped the ball on first aid in our high schools. It's now the principal decides whether a first aid course is helpful in Western Australian schools, which is a bit sad. And then meat after rice. We all know what meat is. Everyone happy with meat?
So this is mainly for your sprain strains, but particularly your ankle sprains. Yep. You know, we get GPs all the time sending a patient in for a cam boot. The worst thing you can do for an ankle sprain is to immobilise it. Okay, they need to be moved. Even if they've got, you know, a tear or a rupture in the ATF, they heal better, the function is restored better with movement. You pop them in a boot, and some people will keep that boot on for weeks because it hurts. And then they end up with a frozen joint, and it takes months of physio to restore the function back into that joint. So we don't use Tubigrip. There was a study came out of Fremantle Hospital that actually showed that there's really no benefit with tubing grip. It's a placebo. So we have an exercise sheet, so which is the E part of MEET, and we give that to the patient, and it's basically putting the ankle through its different movements. And I explain to the patient, if you do this, you're going to heal better and your pain is going to be relieved in a shorter time frame.
Okay, yep, go for it. So these are the resources that I recommend and use every day in my practice. Okay, it's the Ottawa Ankle, Foot and Knee Rules, Radiopedia, I love that site, MD Calc, MD Plus Calc is a free app, and YouTube, because YouTube is wonderful for all your exams. And this PowerPoint presentation and all our presentations that Jacqueline and I have done this week will be on the website, and you guys can use them at will. Okay? All done, guys. Thank you heaps for your attention.
Thank you very much, Cherie and Jacqueline. And let's have another round of applause for all our presenters today.
You can have that now. Thank you. I better grab the water.
So unfortunately, that brings to a close the formal part of our conferences. So the big question now is what's next? So we have your e-learning or online portal, which will be open for the next 60 days. So if anyone hasn't had a chance to have a look at that this week, you've got plenty of time to check that one out. So there's e-learning, 5 different topics there. It's broken up as per the days of the conference, but you can do them in any order, in any which way that you would like. That is provided to us by Mesh Education. So if you do have any feedback, you want to know more about Mesh, please feel free to get in touch with Dylan or myself or Mesh directly, so the contact details should be there. Certificates will be emailed out today in 3 minutes. So at 4:30, you should get a certificate on your phone. It is a new process that we're trying to follow. So we're trying to reduce our waste and just email out all certificates. So that's for the workshops as well as the conference. If you haven't received anything, please give it a couple of days. Check your spam. If you still haven't got anything, please send us through an email and we'll make sure to send one through to you. So that's how you get your certificates. It's also really exciting that we can announce that for this year we've now raised $10,000 for Beyond Blue. So, yeah. So this is a collaboration that we've done with Everest Wealth, and where a portion of all your registration fees go towards a charity, and our charity of choice for this year was Beyond Blue. So $10,000 is pretty exciting, and so thank you all for your support. And we will be back in Bali next year. So if you haven't had a chance to, oh, that's cool, some people are keen. So you haven't had a chance to see that, that is already up on our website. It also is coming in an email tomorrow. So you're going to get an email at 8 o'clock tomorrow. I'm not getting up at 8 o'clock to send it. It is already scheduled to go. So on that email, there is also a link to our website, which has our other conferences, and most importantly, a feedback form. So the whole idea is for Dylan and I was to create a conference that we'd love to go to, and the hope is that you all would love it as well. So if you have any suggestions of how we can improve, please let us know what you did like, what you didn't like, what you'd like to have changed for future events. That will be in the link, the email that you get tomorrow. But I'd just like to finish up by thanking you all. Thank you to the presenters. It really wouldn't be possible without everyone's support. We're really, I guess, yeah, thankful for what we can do, and we love these events, and we hope you guys enjoyed it and can't wait to party with you all tonight at Corner House. Cheers.